All right. Okay, guys. All right. So my name is Talha Malik. And thank you for inviting me. I am an IBD doctor, Crohn's and colitis doctor at SSMC and on staff at Mayo Clinic. And the topic that I've been given today to present on is biologics and IBD. What I've done is, because I only have about 30 minutes or less to do this talk, I've limited my presentation to Crohn's. If I get a chance to do this again, I'd be happy to delve into the data for UC as well. And because I'm an adult IBD doctor, so I think what I'm going to do is try to compare the data we have for IBD in adults and see if how much of that really can be replicated for Crohn's patients in the pediatric population. Okay, my disclosures. Here you go. And so the learning objectives of today's presentation are: one, understand current approach and principles of Crohn's management. Two, understand the role of biologics in Crohn's. And three, know some of the seminal clinical trial data for biologics in Crohn's, and also some observational work that I'm going to highlight, but mostly clinical trials. Okay, so what is the current approach and principles of Crohn's management? So I basically was very happy and pleasantly surprised to see that the adult IBD doctors and pediatric IBD doctors are more or less on the same page. So the three themes that we follow as adult Crohn's doctors when we treat Crohn's patients are: we believe in top-down therapy. This is contemporary theme or contemporary approach to Crohn's. And what does top-down therapy mean? Top-down therapy means that instead of waiting to step up over months or years by using steroids, enteral nutrition, and then over months or years putting somebody on something that is more that has greater data in terms of response rate, you basically start, especially those with high risk of progression, with aggressive and biologic therapy, because that delivers better outcomes in the long run. That's what we do in adults, and that's something that is replicated and is considered to be the current approach to Crohn's treatment in pediatric data and pediatric Crohn's patients as well. There is a slight difference, however, which is that in pediatric principles, they do like to divide patients at the outset between those who are at high risk of progression, even with moderate disease, versus those who are at low risk for progression. The second theme, or the second component of the approach, is treat to target. What does that mean? And this is also something that is common between ourselves and you guys, the pediatric GI doctors and Crohn's doctors. What this means is that somebody comes in, for example, 20 years ago when I trained, if somebody came in and said, I'm pooping blood, I'm having diarrhea, I'm feeling bad, a Crohn's doctor might say, okay, you need to be on therapy. We're going to put you on treatment, go back home, and then come back and see me in 3 to 6 months, and I'll see how you're feeling, without a clear objective target. What has changed now is we're all supposed, as Crohn's doctors, to identify an objective target. For Crohn's, that target is mucosal healing, and in many cases, transmural healing. So this is the second theme, the second component of the approach to Crohn's management is: after top-down therapy, we treat to a target that is objective, and it consists mainly of mucosal healing and transmural inflammation. And this is again a common thing between the two groups. One more thing that I saw in the pediatric group was that proactive therapeutic drug monitoring is prominent among pediatric GI doctors. We do it as well, but I think it's more prominent among the pediatric Crohn's doctors. The third theme, or the third component of the approach and principles of Crohn's management, is health maintenance. For example, do no harm. So if we are going to put somebody on optimal aggressive therapy, then we need to choose the safest option for our kids, which has been tested and tried. And this is something which is more prominent, in fact, in adults, Crohn's therapy, but I also found similar theme when I saw the pediatric Crohn's approach, or when I looked at the pediatric Crohn's data. So again, the three things, if somebody was to ask you what are the main principles of Crohn's management in adult and pediatric Crohn's patients, they are top-down therapy, treat to target, and do no harm or health maintenance. Okay, what about role of biologics in the Crohn's population? So earlier, top-down therapy means that you put these patients on biologics early rather than wait for a few months or years because the best outcomes are ensured if they go into remission or if they respond early on, rather than when they failed one therapy and then you step up to the next therapy and then step up to the third option. So earlier top-down therapy is where biologics play a role, because earlier top-down therapy means you put them on biologics early. What about the other role? It is optimal therapy. So you'll see, and I'm not going to present clinical trial data for immune modulators as much, but I'll present data on biologic therapy. You'll see that biologic therapy allows us to actually achieve clinical response rates earlier and in a higher percentage of patients. And mucosal healing also occurs more so with biologics. And third, again, is safer therapy. If you were to look at the alternative, especially in the adult IBD population, to biologics, the most alternative options are steroids long-term. So even if you used to put somebody on a biologic early on, that also ensures that they are getting a safer therapy in the long run. Okay, so the third component or third objective is to look at the clinical trial data for adults and for pediatric populations with Crohn's. So again, not to spend too much time on this. So in the IBD population, in the adult Crohn's population, we have 1, 2, 3, 4, 5, 6 biologics that we use so far in practice that are approved and have had clinical trial data. And they include the TNF blockers infliximab, the TNF blocker adalimumab, and certolizumab pegol. And these are the names of the seminal clinical trials. There's other clinical trials as well and post-hoc analyses, but these are the main clinical trials that we use when we look at evidence to suggest that these drugs work for Crohn's patients. And then there's vedolizumab, then ustekinumab, and then risankizumab, which just got approved within the last few months. So again, not to spend too much time on the adult clinical trial data for Crohn's, you'll see here, just to summarize this for you guys, if you look at this is clinical response to induction. So if you look at the clinical response to induction, you'll see that infliximab, when it was used back in 1997, when it was approved first, when it was published, the trials were published for infliximab in adult Crohn's population, the response rates were as high as 80%, 60 to 80%. But all of these patients were TNF naive. After infliximab was approved, everything else that came after it, for example, adalimumab, certolizumab pegol, vedolizumab, ustekinumab, all of them had slightly less clinical response rates. One reason was because these drugs may not have been as effective, were probably a little more safe, not as effective, but also because many of these populations were not TNF naive anymore, were not biologic naive anymore. But as we progress to contemporary data, you'll see that with the advent of ustekinumab and risankizumab, we're beginning to notice that there has been an upshift or an uptrend in response rates again. So what we're headed towards now is that we're not able to get as great clinical response rates as infliximab. We're beginning to get response rates in the 50s and 60s again in TNF experienced patients by using safer alternatives in TNF experienced patients. So again, just to kind of summarize, infliximab had the best clinical response rates, and then we had about 10, 15, 20 years of drugs that came out with reasonable response rates, safer regimens, but not much higher response rate, not much more effective, till risankizumab, we just got approved for Crohn's in the adult population. What about clinical remission? Same thing. So when it came to clinical remission, infliximab and adalimumab were relatively more effective, and then certolizumab pegol, vedolizumab, ustekinumab, in the TNF experienced population, the clinical remission rates were high till risankizumab came into the picture, whereas risankizumab, the IL-23 inhibitor now that we use for our patients, has higher clinical remission rates than any of these drugs that came after infliximab. If you look at the maintenance of clinical remission, so what this data suggests is that if you continue those who respond to the initial biologic and you keep them on it for 30 weeks, 40 weeks, 50 weeks, then about 30 to 40% of most of these patients will still be in clinical remission after 1 year. So the thing to note over here is that while infliximab was a superstar in terms of induction of clinical response, if you look at the latest data for risankizumab, it actually beats the data for infliximab as well when it comes to long-term outcome at 1 year. So the only thing to remember here, in case you guys are wondering what's going on over here, is that while infliximab was used in TNF naive patients and had very high clinical response rates to induction, at 1 year, most of the biologics before risankizumab had clinical remission rates in the 30s and 40% range. So this is the adult data. Now let's look at the pediatric clinical trial data on biologics in IBD. So again, this, because I'm an adult IBD doctor, and thank you for letting me do this talk, because this was my chance to actually look at the pediatric Crohn's data as well. And that's kind of helped me, and I'm hoping I can help you guys with the data as well. So for infliximab, there is the REACH hybrid clinical trial that was published in 2007. There's a kids trial, which was published in abstract form in 2020. And there's several observational studies, which are post hoc analyses and independent observational studies as well. For adalimumab, we have the Crohn's induction maintenance trial, the Imagine-1, published in 2012. And then we have the long-term open label extension of the Imagine-1 trial, the Imagine-2 study, which was published in 2017 and 2018. And then we have several observational studies as well. For certolizumab pegol, which is Cimzia, I guess, I'm not sure you guys used it ever, but that's the third TNF blocker we have approved for Crohn's. I couldn't find any single clinical trial done in the pediatric Crohn's population, and I couldn't see any major observational work as well for certolizumab pegol in the pediatric Crohn's population. Then Vido, or Entyvio, as we call it, as it's called in based on its brand. There's no clinical trial in the pediatric Crohn's population for Vido, but there's several observational studies, mostly based on data extrapolated from adult studies. What about ustekinumab or Stelara? So no clinical trial done so far in the pediatric Crohn's population. However, there are at least 2 observational studies that have been done with Stelara in the pediatric Crohn's population, and there's some post hoc work as well from the Unity trials. Risankizumab, which is the newest kid on the block, there's no observational work, and there's no clinical trial for pediatric Crohn's with this drug so far. So what does the REACH clinical trial show? So REACH trial had 2 phases. It had the open label single arm induction phase, in which outcome was measured at 10 weeks. And what this showed was that, again, this part of the clinical trial wasn't a trial per se, because this was single arm induction phase without any placebo or any comparison. What this showed is that clinical response rate was seen in 88% of patients, or pediatric patients with Crohn's. Clinical remission was achieved in about 60% of kids with Crohn's. Take home from this slide is that this shows us, even though it's not a clinical trial, this part of that clinical trial wasn't really a clinical trial, but this shows that infliximab is as good or better than infliximab in pediatric Crohn's is as good or better in terms of induction of clinical response and remission than infliximab in the adult Crohn's population. So this is kind of the summary or take home from this slide. And this was the REACH trial open label comparative maintenance phase outcome at 54 weeks. And they compared the 5 mg per kg IV every 8-week regimen to the 5 mg per kg IV every 12-week regimen at 54 weeks. And at 54 weeks, response rates were 64% for the every 8-week regimen and 33% for the every 12-week regimen. And the remission rates were 56% for the every 8-week regimen and 24% for the every 12-week regimen. So the take home from this slide is that in terms of clinical remission, the every 8-week regimen is far superior to the every 12-week regimen. In fact, the data for clinical remission for infliximab for maintenance of clinical remission is superior to its counterpart in the adult Crohn's population. So again, the summary is that infliximab works probably better than it works in the pediatric Crohn's populations than in adult Crohn's populations, and with comparable safety profiles. So Tisket's trial of top-down versus step-up therapy, I don't think this has been published as a manuscript yet. This is published in abstract form. And what this shows is that if you put somebody on top-down therapy, which as I said was to put kids on earlier biologic, with or without traditional immune modulators versus place them on enteral nutrition with steroids and then step them up over the next few months. They saw that clinical remission rates in the group that received a top-down therapy, this is pediatric literature, was 41% versus 12% in those who received step-up therapy. So this kind of is where the evidence is coming from for the top-down therapy being superior to step-up therapy in the pediatric Crohn's population as well. Okay, so this is an observational study, risk pediatric Crohn's study by ProKids Research Group used propensity score matched analysis in 2014 and suggested that early anti-TNF monotherapy, infliximab or adalimumab within 3 months of diagnosis had higher corticosteroid and surgery-free remission at 1 year compared to exclusive enteral nutrition or corticosteroids followed by traditional immune modulator therapy. So again, same concept. The take home here is that those kids who were placed on a biologic with or without immune modulator early on within 3 months of diagnosis had better outcomes than those who were not placed on that early biologic therapy, which is supposed to be more optimal, more effective, and in many cases, in my view, much safer than the alternative, which would be to use steroids a lot. And then there's some more observational work that I saw in the literature on infliximab. So Lee and colleagues in 2015 showed in South Korean cohort that top-down therapy, which is infliximab or adalimumab earlier, compared to step-up treatment led to higher rates of long-term remission. Kang and colleagues also in 2016, also from South Korea, showed that top-down therapy compared to step-up treatment led to higher rates of mucosal healing after 1 year of treatment. And then the last one that I found was Kugatherson in 2017 demonstrated that early treatment with anti-TNF agents were associated with significantly lower risk of developing penetrating complications without reducing risk of stricturing complications. So for penetrating complications, which is kind of the higher level complication, seems to be the outcome seems to be improved if you put them on early treatment, if you treat them early with TNF blockers. So what about adalimumab in pediatric Crohn's, or Humira, Amjevita? That's kind of those are the brand names. So the first evidence of effectiveness, the first case series that was published in 2008 described 10 pediatric patients, both Crohn's and UC, who had failed infliximab and were followed on and were placed on adalimumab for 26 weeks. And clinical remission was noted in 80% of them at the end of 26 weeks. So even though this is not a clinical trial, it's a case series, it's case series, but just looking at the number in people who had failed infliximab, this is superior to anything that infliximab has done in an observational study or in a clinical trial setting. So again, the take home here, just based on that first sentence, is that adalimumab works better than in pediatric Crohn's populations than it does, or I shouldn't say based on observational work, but I strongly, based on this data that I've looked at in the last 2 weeks, I feel adalimumab works safely and works more effectively in the pediatric Crohn's population. The second case series was published in 2008, same year, revealed that 50% of IBD patients were able to discontinue steroids for 3 months or more while on adalimumab maintenance therapy at 26 weeks. The third case series that I found for adalimumab in Crohn's, published in 2009, revealed clinical remission in 6 of 9 IBD patients, which is 66%, receiving adalimumab at 24 weeks. Okay, so let's talk about the clinical trial. So the seminal clinical trial of adalimumab in pediatric Crohn's was the Imagine-1 study. This study, I think, was published in 2012. This study looked at the safety and efficacy of adalimumab double-blind maintenance dosing regimen following open-label induction for pediatric patients with moderate to severe Crohn's. Make sure I'm not running behind. So 192 patients enrolled in the open-label induction arm, and 188 continued to completion of induction at week 2, with response rate noted in 82% at week 4. So again, just to kind of summarize this again, if you remember the Crohn's data, if you remember the adalimumab data in Crohn's, the response rates were in the 30s and 40%. This is 82%. So adalimumab, as opposed to adalimumab in the pediatric Crohn's population, as opposed to the adult Crohn's population, works almost as good or as good as infliximab, even those who had failed infliximab in the past. The 188 patients who completed induction were then entered into the double-blind maintenance arm based on weight, with those more than 40 kilos receiving the 40 or 20, and those who were less than 40 kilos received the 20 or 10, every 2 weeks for 48 more weeks, total 52 weeks, with primary endpoint of clinical remission at week 26. So what was that outcome? So those overall were 34%. Those who received high dose adalimumab, their response rate, their remission rates were 39%, and low dose adalimumab was 28%. So what does that mean? So we used the 160, 80, 40 every 2 weeks. The pediatric population, based on the high dose ADA, what that means is those who are more than 40 kilos get the adult dose. Those who are less than 40 kilos get the 80, 40, and then 20 every 2 weeks. So those based on the kilograms, their response, their remission rate at 26 was as good as what we achieved in the adult Crohn's population. Clinical remission at week 26 among infliximab naive patients, those who had never been on infliximab, their response rates or remission was 57%, which was superior to that achieved by infliximab. So I would say, casually, I would say that infliximab, it had advantages of being given first time in naive patients, was the superstar for Crohn's in adults. But I think adalimumab basically does as good. And adalimumab basically trailed behind infliximab. Whereas in the pediatric Crohn's literature, adalimumab and infliximab are like this. So both of them work really well, including those who get adalimumab after infliximab, they also seem to do well. But those who get adalimumab as naive patients, they do as good as those who would get infliximab. So Imagine-2 was a long-term open-label extension of Imagine-1. Imagine-1 lasted a total of 52 weeks, so about a year, and included the first 4 weeks of open-label induction phase and then 48 weeks of double-blind maintenance phase. Imagine-2 was an open-label extension of Imagine-1 and lasted a total of 240 weeks, so about 5 years, and using non-responder imputation starting from week 52 of Imagine-1 and enrolled 100 patients from Imagine-1. And this showed that at the end of 240 weeks or 292, if you count all the way from the beginning, 41% were in clinical remission, 48% had clinical response, 63% were free of steroids, and 30% were off traditional immune modulators. So again, reasonable, good data for adalimumab in Crohn's patients, in the pediatric Crohn's patients. In perianal Crohn's, same thing. In Imagine-1, 36 of the 188 patients had perianal fistula, and at week 12, 44% had closed and 52% had improved based on the NRI analysis. And at week 52 of the total, based on NRI analysis, 50% were healed and 58% were considered improved. In Imagine-2, at week 240 or week 292 from start of Imagine-1, 36% had fistula closure by the NRI analysis and 91% of those observed. Of those who entered Imagine-2 with fistula closure, 64% by NRI and 100% by observation had fistula closure at week 240. The difference between observation and NRI is basically its intention to treat, where they impute, for example, if somebody began the trial and left the trial because they felt very good, they were considered to have had good outcome. If somebody left the trial because of any other reason, where they did not know what the reason was, they were considered to have had failed. They would have had a negative outcome. So based on the NRI as well, it seems like response rates and remission rates are very high for fistulas as well. So based on a sub-analysis of Imagine-1 and also based on several other observational studies, combining adalimumab with traditional immune modulators did not seem to increase response rate, but based on adult data and data extrapolated from infliximab pediatric studies, combination therapy recommended for high-risk individuals, especially those who had failed infliximab. In regard to therapeutic drug monitoring, there does seem to be some evidence suggesting that variably higher levels of trough adalimumab levels with variation between 5 to 17 micrograms per milliliter leads to higher levels of mucosal healing, endoscopic remission, and histological outcomes. So what they're saying is that there is less of a evidence to combine therapy like adalimumab and azathioprine and infliximab and azathioprine in the pediatric population unless they are high risk. But I don't know if you guys were watching closely. There was a randomized trial published last month in which they saw that if you combine adalimumab with methotrexate low dose, the Crohn's patient that you give this to actually had a statistically significant better chance of staying on therapy and in remission compared to those who were combined, who had infliximab and methotrexate combined, or who had infliximab or adalimumab with placebo. So the take home is that adalimumab seems to work well with methotrexate in pediatric Crohn's. Infliximab seems to work better with azathioprine, especially in high-risk individuals. So certolizumab pegol, Cimzia, no clinical trial or major observational research. So I don't think any of you guys use Cimzia, or maybe use it if you guys have no other choice. Anyway, there's no major evidence, observational or clinical trial data for pediatric Crohn's. Vedolizumab, no clinical trial, but a few observational studies, mainly adult observational studies with adolescents, children in sample. The mucosal response rates were variable between 6 to 63%, kind of a hit and miss. If you have no other choice, I think we should consider Entyvio or Vedo. Overall clinical and mucosal response was higher in those who were TNF naive. What about UST? So Stelara, no clinical trial, but 2 retrospective observational studies or series. Diane et al. In 2019 studied 52 pediatric and adolescent Crohn's patients and noted steroid-free clinical remission at week 52 in 40% of them. Shavanis et al. And colleagues in 2019 studied 44 TNF experienced children with Crohn's and noted clinical remission at 12 months in 39% of them, which is kind of comparable to the data for ustekinumab in the adult Crohn's population. Risankizumab or Skyrizi. So no clinical trial or observational work in children. At SSMC, where I work, we've given risankizumab to 10 patients. And the youngest one that we've given it to was 18 at the time of induction and naive to all therapy. We're awaiting assessment of response. I tried to get away with it and try to give it to a 16-year-old as well, but they declined the next day. So I didn't want to fight that battle. So I said, you know what, let's just wait and try for the other guys. So we don't really have any data so far on pediatric Crohn's for risankizumab. So summary, current approach to Crohn's treatment is similar for adult and pediatric patients and includes principles of top-down therapy, treat to target, and prevent harm. Number 2, biologics play a prominent role in treatment of Crohn's in adult and pediatric patients and provide for earlier, optimal, and relatively safe therapy. There is large amount of clinical trial data for a variety of biologics in adult Crohn's patients, whereas clinical trial data is largely limited to the TNF blockers, infliximab and adalimumab in pediatric Crohn's. 4, clinical trial data for infliximab and adalimumab in pediatric Crohn's demonstrates that these agents are at the very least as effective and probably very likely more effective in the pediatric population with Crohn's with a comparable safety profile. And lastly, data for other biologics in pediatric Crohn's is mostly limited to observational research and so far suggests reasonable effectiveness of ustekinumab equal to the adult counterparts in both TNF naive and TNF experienced patients, and of Vedo or Entyvio mainly in naive patients. So this is it, and this is kind of a list of 12 or 13 papers that I looked at. I think most of what I talked about today, you'll be able to find in one of these papers. Okay, guys, thank you.